from Lisa Block over in Gig Harbor. She's the pediatric dentist. And the patient is missing a lateral incisor and has a peg lateral incisor, significantly retrognathic, so they need jaw surgery, so they're going to go to Seattle and get an assessment there. And then they're going to come see me as the orthodontist, but Lisa's not going to do the restorative. Stephen Hansen is going to do the restorative. Okay. All the parents want to know is, when do I get my implant? That's the only thing they care about. At every step along this way, we want a number of things to happen. We want them to hear the same story over and over again. Why? It creates a comfort level. Obviously, they get knowledge, but now they're hearing the same story at the periodontist or the oral surgeon or at the restorative dentist. That makes them think that we all know that they are doing the right thing because they aren't hearing something different, and you will get case acceptance. So when you start talking to them about, well, I'm going to open space for an implant. Well, when does the implant come? Not till you're done growing. What about the restorative on this little itty bitty tooth? Well, Dr. Hansen is going to do that mid-treatment in the middle of my orthodontics. So you're going to create a roadmap that identifies all the stages of this. And all of that's going to get done before your oral surgery. But the implant's not going to get done until you're done growing. And if it's for tooth number 7, I hope I get to it tonight, but I'm going to create a case for why I don't like seeing implants in the anterior. And I haven't talked to Tom about this, but I've been around long enough now. I'm seeing implants in patients that I treated at age 12, 13. They got implants at age 19, and now I'm seeing them as 43-year-olds, and I'm retreating them. They didn't continue to grow. They are females. But the alignment's all out of whack, and the solution is really difficult. And in this day and age with resin-bonded bridges, I like that option way better. Your success rate, depending upon how you do it, is up to 97%. And we'll talk about how you can augment the ridge both with hard and soft tissue to create the profile of a resin-bonded bridge. In the old days, you all hated resin-bonded bridges because you bonded them to 2 teeth. So you had differing forces, so they always debonded. But if you only have a single wing, especially in a lower incisor, I mean, do you really want to do an implant on a lower incisor?
Not my favorite spot.
No. So where did this idea of interdisciplinary treatment come from? Well, I don't think it necessarily started here, but it created an opportunity for education, and that came from the Northwest. And you'll be shocked at the small town ideas that grew worldwide and where these people came from. Pierce County Dental Society. So all of these people, you might recognize them. There's a tremendous legacy. There's Frank and John Coyce, and they practice in the little office that Keith still has, and Michelle, or Rachel, sorry. She's my patient, I can't even remember her name. Rachel, they exist there now. And what happens when you put 2 prosthodontists together who get really big? Their egos get in the way, so they gotta go in different places. So they go to Seattle. Dave Matthews, tremendous periodontist, and if you aren't sure, you just have to ask him and he'd be happy to tell you. And then of course this man who is a pioneer in orthodontics and education. If you never got a chance to see him lecture, he was the best teacher in the world. So you put all these guys together and they went around the world talking about interdisciplinary treatment, and they created really what I think is the bread and butter of what we do. And at the time, they were called the Trio. And I know them very, very well through different avenues. And we'll talk about that because it had a lot to do with why I'm here tonight. So you might imagine that they were probably in a study club. And you might imagine that that study club was generated by either Frank or Vince, and they asked Dave. And while they were in a study club, and it was called the Northwest Network for Dental Excellence, it was not created by either one of those 3. It was created by this man, Ralph O'Connor. He's a restorative dentist in Lakewood. His daughter was a classmate of mine, Beth O'Connor, and she just retired. Although I think she's in the office bugging her son, who's taken over her practice on a day-to-day basis. And Ralph got really irritated. He was sending these cases out for coordination of care, and great work was getting done, but they were coming back reportedly ready for restorative, but it wasn't set up the way he wanted that. So what he said was, I'm going to pull Frank and Dave and Vince, and his endodontists were John West and Dave Steiner, and his oral surgeon was Mark Carlson, and then he had another prosthodontist who's the best glass man out there, Bob Winters, and they got together every month. In the afternoon, they all missed clinic and nobody ever missed a meeting. And it was very regimented, but its purpose was solely one, and that was to learn how the other people thought. You were going to teach endodontics to the orthodontist. Because what you want to do when you see a patient is get out of the bias that I'm an orthodontist and I'm going to look at how much crowding and I want to use Invisalign on you and my production is down, so I need to start. You're going to get out of the idea that I'm a restorative dentist and I'm looking at caries and I need to figure out which teeth are going to be the abutment for this bridge. Instead, I want you to look at it through the eyes of a periodontist, which I know scares us. So they created this study club. And as things go, when people get more mature, it starts to wane. People retire. And so it went away. And about 7 years ago, Dan Cook, the pediatric dentist, said he wanted to get the band back together, so he asked me to join because Vince had passed away. And so I was very honored, but it was really cool to sit in a room with these guys that had been doing this for 30 plus years, doing it the same way. And it was a really cool thing because what Dan did is he brought the pediatric residents from the UW down so they could watch us do our thing. The one thing that I gathered in watching them discuss things was a transition. In the old days, you know, periodontists and prosthodontists did a lot of specialized techniques. They'd section a root to save a tooth and all these heroics. And then everybody got out of that because it was just as easy to do an extraction and place an implant. Now implants maybe aren't the panacea that we thought they were. No implant has been in a mouth for longer than 30 years. So where is it going to be when you put one in at age 25 when they're 80? Nobody knows. So I saw a change, especially in Frank and Bob, of saving more teeth, taking the effort to do the endo and make sure they can hold on to that tooth for a longer period of time. So there's a case, and this was the case that spurred Ralph O'Connor to pull these people together. And Dave Matthews and I did a tribute to Ralph and Vince Sr. It was called the Interdisciplinary Treatment of a Patient with Amelogenesis Imperfecta Case Report, and we followed the patient 35 years later, and then we published it in the, I can't even remember, Journal of Aesthetic and Restorative Dentistry. And if you want to go look it up, or if anybody wants that article, let me know. It was a crazy case. We even had to, I had original paperwork from some of the specialists that were involved before this group got involved. Beth O'Connor gave me some of the paperwork and it had been damaged in a fire. So nothing was digital. It was all paper and you could see the burn marks on it. It was pretty cool. So the significance of the study club is to learn from your colleagues, to think like the other specialists. That's why we're here. That's why we're learning how to do that. And over the years, I've had different study clubs, a lot of them. This one doesn't exist anymore, but it was always at 6 a.m. on a Friday morning. And the reason we did it is because we thought it wouldn't interfere with our family lives. But when you get up at 5:30 to go to a meeting at 6, it still gets in the way. This was our Monday night study club. And That one still exists, and it primarily, everyone got so excited because Keith was a part of it. And I don't know if you guys are old enough to remember the old E.F. Hutton commercial, but we used to get together because anything Keith said, we would listen to. So it was really gracious that he would come and we would sit and talk cases. We still get together, pretty much everybody in there. Ralph isn't there, Keith's not there, and Chacon's not there. But it's been the same people for more than 20 years. So that's kind of fun. I have a Spear study club. Ashley Hoders and I run it. I kind of like it because of the format. You have modules that you can watch, and so it's easy for some new restorative dentist to get involved and have a routine or have kind of a pattern that every meeting's going to go through. So what you're seeing is a series of texts. Now, dentistry is fraught with the problem of isolation. We graduate from school, we go to offices, we buy our own practice, and we sit in our office every day and we figure stuff out by ourselves. And we were trained that way. You went to dental school and you competed against your future colleagues. And so there's this whole competition thing. So I would press you to say, if you're not talking to another dentist every day, start. You will have so much more confidence when you can share the misery of your day or the question of what am I going to do with this. So I have ortho study clubs, and all of those texts are the non-UW guys. Those are Angle guys from Oregon. They're all trained at Oregon Health Sciences. I literally talk to them every day, and we all throw cases at each other. I've been doing this for 30 years. If you think I know how to treat every single case, or somebody's borderline and I want some help, would you extract? That's where I send them. Now, I also have some former students, because I teach up at the U, and they're young, ambitious guys, and I'll send something to them and I'll say, what would you guys do in this case? And then I have my old cronies that were my classmates, and I send stuff to them. The old cronies will probably give me the answer I'm kind of looking for. The young, ambitious guys will try things that I've already tried and didn't work, but they don't know any better yet. But if you took all three groups and you blindfolded me and showed me a case and showed me what the answers were, I'd be able to tell you which group. We all have biases based on our training or what we continue to learn from. So why am I speaking about interdisciplinary treatment? My office, these are my team members, and on a day-to-day basis, they take very good care of me. Well, a long time ago, somebody else took very good care of me. So Vince was one of my teachers, and 31 years ago, he came to me as a resident, and he said, hey, Doug, my partner in the building, there are 2 orthodontists here, needs to sell his practice, would you consider doing it? And I went to PLU, and I was not coming back to Tacoma. I already had a place picked out in Mill Creek. It was going to be awesome. I was going to build a building with Roy Caldestad, because he was a restorative dentist. He wasn't an endodontist yet. And when you're a resident, you don't really realize how important within the field some of your faculty are. They are just nuisances getting in the way of you getting out of the program. And Vince was in charge of our thesis and our research, and so that was a pretty big nuisance. So I went to the meeting in San Francisco, and there were 2,000 orthodontists in the room, standing room only, to listen to Vince. And I thought, I'm an idiot. Of course I'm going to come to this. And I bought Tom Parksdale's practice. And so it was pretty simple. There were 3 chairs over here, and there were 3 chairs over here. This was Vince's office. This was my office. And we shared a common desk. And I used to pace this little hallway because I wasn't very busy early on. And Vince would say, quit pacing, you're making me nervous. Come over here and look at this case. And he would show me a case. And then Maura, his assistant, would bring out the models. And my knowledge grew exponentially, and he really fostered the interdisciplinary aspect of it. And he would take me to study clubs, and then I would see that case, a few years later on the big screen somewhere, and I was very fortunate to have seen it hands-on. So when you look at these cases, how are you viewing them? If you're a restorative dentist, you're looking at the missing teeth thinking, well, am I going to do a bridge? What am I going to do with that space? If you're the periodontist, you're looking at this going, well, what's he going to do? Is he going to extract? How much attached tissue do I have here? If you're a restorative dentist, you're looking at the depth of the overbite, how ugly that crown is. This is the kind of patient that we were talking about earlier that comes in and just says, I want bleaching, but really they have a host of things that really need to be viewed and corrected. So my goal here tonight is to point out things that you want to look at through the eyes of other specialists, so that you're starting to see what I'm seeing, so that when you refer a patient, you know what to tell them about what I'm going to do. Because I do the same thing when I send them back to you. I don't just say, go see your dentist, go see Dr. Kim, he's going to talk to you about doing a bridge. Well, he doesn't want me to talk to him about doing a bridge. We set up the case and we coordinated it with Tom for an implant. Now, I always ask, do you know much about implants? Thank God there's Google. I can sit down and show them what an implant is. When you do that with Google, make sure you put in dental implant or you will be shocked. Yes, I've done that. So what creates an interdisciplinary case? Do you have to have missing teeth? And yeah, we split that ridge and we put implants up there. Do you have to have significant perio defects? Does it have to be big and nasty? And is this a problem with over-eruption or tooth wear or gingiva that's in the wrong position, delayed active or delayed passive eruption? All of these cases get me to a point within my practice where I look at it and I say, more times than not, when is it not an ortho-only patient? Every time I'm looking at it through the eyes of the periodontist, because I don't see 12-year-olds. I see little 40-year-olds, because I'm setting up the case for when they're going to be 40, and I want to set them up for success. Because if I treat every case non-extraction, and I hear all the time, you can't extract, it's going to compromise the airway, it's going to destroy their face. None of that's true. But if you are somebody who says, I don't want extractions, you're on the same mentality of somebody who says, I always want extractions. They're the same. You have to identify the individual needs of the patient comprehensively, whether it's restorative, whether it's perio, or whether it's ortho. So I look at some of these cases and I look at it and I say, is this an ortho-only patient? Am I going to sit in my office on a Sunday night knowing I have to share the result of what we're going to do with the mom on Monday morning all by myself? No, I've got the opinions of other specialists. What about this one? This looks pretty routine, right? But look at all of that thin gingival architecture. Am I just going to treat this non-extraction? I need the expertise of other specialists in order to help me make decisions to give guidance to these families. And when I look at the perio, I look at it in 3 categories. I look at it at the status. That's mean where they are now. And those are things you can assess. Then we're going to look at the consequences. The consequences are, what is the perio going to do subsequent to my treatment? Am I going to make it better or worse? If I'm going to make it worse, I better step up and fix it first. And then objectives. What am I trying to do with the position of the teeth that's going to help the restorative dentist or the periodontist? Am I going to generate bone by over-erupting a tooth to extraction so that you've created an interproximal bone that can then accompany a papilla to support adjacent to an implant? So I look at these things all the time. I know it's crazy, I'm an orthodontist, but I'm very curious about the perio. Why? You can only move teeth where there's bone. It's the most important thing I need. I don't need better brackets. I don't need better aligners. I need better bone. Because if there's no bone, I can't move the teeth there. So when you're doing this, first I look at where do I want that bone to be? And my tooth movement can affect that. Tooth movement is what I characterize as a clinical modifier. So let's look at a case real quick. Now, when I do my study club, I quiz them. And I'm short on time. So what I would usually do is I would say, well, what do you see? Okay? So we talk about the occlusion. Well, simple. It's class 1 malocclusion, right? And you've got 2 crazy canines out here. And when we were trained, this happened on Wednesday. I was up at the U and I teach the grad pros, grad perio, and the grad ortho students all combined. And so I asked them, I said, you have to give me an option. Doesn't have to be the right option, but it has to be different from the option that came before you. Because that's how we were trained. We had 6 residents in the room. That back when we had slide projectors, and the faculty would go around the room and say, give me an option, give me an option, give me an option. You just had to come up with something different. So somebody, oh, I know there's an orthodontist here. Give me an option.
An option? You could certainly extract premolars. You have a blocked out, I believe you blocked out lower right canine. So you could certainly extract premolars as a first bias, as a viable option.
Okay. Somebody give me a second option.
Take out the cuspids.
Okay. Somebody give me a third option. Can't be either of those 2, and it doesn't have to be right. Somebody going to expand?
Maxillary SF2 expansion and bring those cuspids.
Okay. So when I presented this to the residents, I quizzed the ortho residents to come up with it, and you counted the teeth because you saw the blocked out canine. They did not. So sure enough, when you look at it, that's where the canine is. So another option is, could you open space and drag that tooth in? No. You are correct. We are not doing that. So that's where the face is, that's where the canine is, way down there. So we're not bringing that in. So what did I do? Well, one of the options is, and we went through those, I want to know what the other specialists are looking at when I'm making this decision. And so I'm going to show you something that I tend to do every once in a while. Sometimes I sit in my office and I'm thinking, how can I reach out to people? And I just treated a pretty cool case. So what I do is I send them the end result. And I send them the beginning. And I ask them that question. And I do it via text. So I did that to about 20 colleagues. So does everybody see what I did here? Took out how many canines? 3. We did not mess with that canine down there. We were not even going close to it. So I did that, and the first person is a really good friend prosthodontist, and this was his answer. And he said, well, I'm hoping you did some rhinoplasty, and given that he's an orthodontist in hiding, the arch is very narrow, so canines maybe aren't as blocked out as they look, so he would look at the idea of expansion. And I said, well, how much expansion would you need? And he laughed and he said, or just enough. And he said, well, quite a bit, really. And I said, well, can you see what's going on in the mandible? And he said, given the exaggerated curves of Wilson, you won't really need to expand the mandible. Which arch is the most important when you're dictating expansion? The mandible. You can only expand the maxilla as much as you can expand the mandible. It's so easy to show examples of before and after with the maxilla because you have a suture. You don't have a suture in the lower. You have a curve of Wilson. Okay, you're going to upright the molars because you've all seen the CBCT that says the airway is narrow, so you're going to upright them and somehow that's going to open the space down here. Well, how much expansion do you think that is? 2, 3, 4 millimeters, but you've seen the expansion with an 8 millimeter diastema. If you can't expand the mandible 8 to 10 millimeters, why are you expanding the maxilla? Only if there's a posterior crossbite. But if you don't have a posterior crossbite, you're dictated by what happens in the lower jaw, not by what you do in the upper. So he was shocked when I showed him where the canine was. And so he said he's never seen one before, so how did I obtain? And I didn't. And so he came to the table with a bias. What do you think his bias was? Non-extraction, expand, airway. This was another person. And she said, let me see, expansion and 27, and how much expansion would I need? Triangular arch, mandible and maxilla, very constricted. Did you consider SFOT? I said no, not this time. Could you have expected the same result extracting 5, 12, and 21? I'm looking at it from the aspect of the bifurcation of 5 and 12. What kind of restorative, or what kind of dentist is this? If they're asking about the bifurcation of premolars. Yeah, periodontists. They're the only ones that care about stuff like that. And rightly so, because that's what I need to know. If there was a significant bifurcation, I'd have taken out premolars and dragged the canines in. But if there's not, then I can treat them very much like a canine. So I need that information, and that's why CBCTs are so critical. If you can't see that on a pan or a Ceph, but you can from a CBCT. Then there's this one, and he talked about jaw surgery, and he really didn't ever want me to send a case like this, and he was hoping he'd never see one. What kind of person is this? Oral surgeon. They only want to do the least amount of work that takes the least amount of time. And I don't blame them. They have everybody blocked or knocked out. Then there's this one. Let's see. You're so constricted. Hopefully you didn't extract any buys. And is that 27 floating way down there? And I said, it is. And I said, how much expansion would you have to do to prevent the extractions? Well, according to Piper, which I just went to again at the Spear course Friday, Saturday, you should scan his TM joints first before expansion to see if the joints are structurally sound and have adequate vertical dimension with the disc complex, or if that's contributing to the retrognathic mandible. What kind of dentist is that? One that's not working anymore. TMJ doc. So that was that case. Now everybody says that extractions are going to hurt the face. Extractions are only going to hurt the face if the face is flat and you have less crowding than teeth you're going to take out. It's a very simple math formula. If you have 10 millimeters of crowding, right? So you would then have to create 10 millimeters of space. Well, what if you take out 2 teeth? Take out 2 premolars, that's 14 millimeters of space. 14 minus 10 is 4 millimeters. Each of the premolars is 7. I'll give you 8. So 16. All right? So you end up with 6 millimeters of space left over after the extractions. You have to split that because that's 1 on each side. So if you're at 8, that's 4 millimeters. And you're going to close the space. Well, when you close space, it's reciprocal. So half from the back, half from the front. So you're going to retract the incisors maybe 2 millimeters on a 10 millimeter crowded. How is that hard tissue going to affect the soft tissue? Well, it depends on the soft tissue. If you have Paul Newman and you take out teeth, he's going to look like he was hit in the middle of the face with a baseball bat. He's got tiny little lips like mine. If the lips are already out in front of the nose and the chin, well, then taking the teeth and the lips back 1 millimeter is inconsequential. Will it affect the airway? No. And I can go through the literature on that with you as well. The poor man's way, if you don't trace the Ceph, to know whether you are going to affect the face a whole bunch, ideally, if you draw a line from the nose to the chin on the outside, you want the lips to be just shy of that line. If they're ahead of that line, then you can extract all day. They'll come back to a point that's perfect. If they're well back of that, well, then you want to be careful. Now, still, extractions may not do anything depending upon the severity of these crowding. So cookie cutter stamping, the idea of extraction, non-extraction, doesn't work. So why are we looking so hard at perio? Well, because it's the thing that gets orthodontists in trouble more than anything. And Vince wrote an article. He was the editor of our journal way back in the day. And essentially, according to the NAIN study, everybody that's older than 30, 47% of them have some form of perio. Not necessarily severe, only about 9% mild, moderate's 30%, and severe is only about 8.5%. But it's a ticking time bomb if you aren't aware of it going into it and you start moving teeth. Because when you have inflammation and you move teeth, you lose bone. It's just the mechanics of it. So if you talk to the claims manager at the AAO, the #1 lawsuit against orthodontists is perio, whether they didn't address the perio before or during treatment. That's where you get into trouble. And it's ahead of TMJ or root resorption. So what do we do about it in regards to the perio? Well, it's not so much what I do about it as an orthodontist, it's what we don't do. Never start without perio charting. So when a patient calls me, I call your office and I want the perio chart. And that seems pretty typical that I'm always going to get a perio chart because you guys always do that. But I'm not always, or you're not always the first call. Sometimes I'm the first call for the patient, especially after COVID. People were sitting on the couch, getting on Zoom, looking at their smile going, I got to get to the orthodontist, but I haven't seen a dentist in like 20 years. And they'll list somebody as your restorative dentist. But there's no perio chart. So when I go in, the things I'm looking for, of course, sulcus steps, bleeding on probing, bone loss infurcations, recession, all of those things are critical. But the two that I can account for at an initial exam are bleeding on probing and recession. Because bleeding on probing means you have inflammation. And if you have inflammation and you move the tooth, you're going to lose bone. If you already have recession, remember that the level of bone is always 2 millimeters at least away from the gingival margin. But sometimes more if you have a dehiscence. And as soon as you start moving the tooth, that thing unzips overnight. You put the braces on 6 months in, you've been seeing the patient regularly, and then the mom comes in and goes, what about this? And it looks like it's mid-root. And you freak a little bit, and then you call Tom, and he bails you out. It's great. So what's the big deal with recession? Well, it's an apical shift of the gingival margin, and it's an underlying bone problem. It's not a gum problem. It's a bone problem. That's why bone is the most important thing. So when we look at a dehiscence, I asked Dave Matthews, I said, show me some literature, some slides that you've used in the past on how to do this and how to understand it. And he gave me these cartoons that looked like he drew them on his kitchen counter. So you have an attachment level, you have a sulcus depth, and then the bone is supposed to be 2 millimeters relative to that, and you have an epithelial attachment that's 2 millimeters. Okay, a dehiscence, you still have everything normal up here, but the bone's way down there. That's the ticking time bomb. And that's what shows up when you start moving it. So is this just a really old slide that's yellow, or is there some reason why it would be yellow? It's from iodine. Iodine is what they used to use to identify where the mucogingival junction is. So that shows us that we have no attached tissue here. Iodine stains differently between mucosa. So what Dave would do back in the day, because he didn't have access to CBCT, he would anesthetize the patient and sound the bone. Well, I don't want to do that for sure. That means I'd have to get anesthetic in my office, and I don't want to have anything to do with that. So you can use a CBCT to get 3D analysis to assess bone. But please be careful, because you need to be aware that in some circumstances it identifies an increased risk that is not there. And Dave Matthews really takes issue with the volume of CBCTs that then dictate some gingival procedure. Because he looks at it and he goes, Doug, I can show you grafts that I did 40 years ago. I can also show you patients that I chose not to do grafts and I followed them over time and they were fine. So just because you see something on a CBCT doesn't necessarily mean you need a graft. And there's literature out there that shares that with us. So what are we using the CBCT for? We're identifying risk. And what are the risks? I want to know where these teeth are moving, and not just the amount. It's not 2 millimeters, it's not 4 millimeters. Are you going to tip the tooth? Are you going to move the root of the tooth? Are you going to rotate that tooth? Those are the qualitative measures that we want to be aware of. And nowadays, I can share that with the periodontist. So tooth movement is what I call the clinical modifier. As they exist, they're fine, but as I start moving the teeth, that's when they might need the periodontal intervention. So we're going to talk about how we assess the risk using some digital ways to go. This is my family. So this is my daughter when she was 18 months old. The only word she knew was bird, I think. She got married, my mom and dad, and then this was 9 days ago. And she just had her first baby last Sunday, so that was Saturday, and it was 11 pounds, 3 ounces. So we already have recruiters from Alabama. They're ready to adopt that big boy. So my daughter's first grandchild, but not my first grandchild, Janice, she has 4 kids, so now we have 7 grandkids. So family's really important to us. 2 of them live on the East Coast in North Carolina, and we don't see them quite as often. Janice goes out there to visit them all the time. And then my other passion is I like to golf. So if you text me about a patient, I will get back to you 100%. But there's a pretty good chance it'll be from my phone and I will be on a golf course. It's on the weekend. I travel down to La Quinta every weekend. So play a lot of golf. Not very good these days. Old age is tough to come by. So what are we doing from a digital standpoint? Well, this is Edward Engel, and this is his famous quote. And in this day and age, we have to do better than this. In the old days, it's very important to get the teeth to fit, and we'd sit around in these Engel Society, and we would make sure the teeth fit, and we would score them and grade them, and we'd evaluate them and judge them, and it was very judgy. I'm chair of the admissions committee for the Engel Society for Washington, Oregon, and British Columbia, and we're doing better. And we have to do better within our practices. And I think the digital age has allowed us to do that. You know, when we look at things from an orthodontic standpoint, you know, these are the standard of care things that we look at. Stability, periodontal health, TMJ, growth and development, the occlusion. We do that routinely. Going better means I've got to create a positive experience for not only the patient, but for the family. I'd like to shorten the treatment time. I'd like fees to be affordable. The old orthodontist and the young orthodontist are visiting with each other. And the old orthodontist says to the young orthodontist, boy, I wish I could have charged what you're charging for fees. And the young orthodontist says, when you were practicing, you bought a Mustang. How much did that Mustang cost? $3,500. And how much did you charge for a case? $3,500. Well, I wish I could charge as much as a Mustang these days. So we need to be able to do something with our fees to keep them affordable. And the only way to do that is to scale your practice. And there are a lot of ways to do it, but digital is a good start. And so our practice is really digital. Then the other aspect is the same experience that you guys are having in your offices. You have to make this a positive experience for your staff. You have to have things be reproducible so that they can do it over and over, so they can become efficient at it. It has to be something that you can manage financially as far as salaries for your staff. And it has to be a fun process for your staff that allows them to be involved in the coordination of care. It can't just be on the doctor to do all of this interdisciplinary treatment. You have to train your staff to think like this, so that the conversations I'm having with them help me out. And so in orthodontics, I want everything to be customizable. My staff sits around, I swear they watch more TikTok videos at my office than they do at home. And I do things for my staff that maybe other practitioners don't, because it's competitive. And here's one thing that I do. So on Thursdays, I'm done at noon. And we used to have the patients still come in and do things with the staff that only I don't need to be there and they can do, like records or something like that. Well, when COVID finished, the patients stopped getting scheduled in the afternoon. And I hated the idea that they were going to just sit around till 3 o'clock all by themselves. So I sent them home. But I still pay them for that time. So they might be able to sit with their friends at some bar going, yeah, my office, and I get paid X amount of dollars. And their friend's going to go, well, I get X plus 1. Oh, you should come work for me because you're going to get paid more. Yeah, but does your boss let you leave at noon and pay you till 3:30? No. Now, if I paid them an extra $1 an hour and cut them off at noon, it's probably a wash. But they can't have a conversation with anybody else in their community that says, I'm getting a benefit from my doctor that they're not going to get anywhere else. I'm not suggesting you go home and do that. I've just found ways to create value in what they're doing so that they value what I'm doing for them. And as a result, I think we keep staff. The only thing that keeps killing my office is pregnancy. It is the bane of my existence. So ordinarily, I'd be going through all these things. So let's talk about digital. Now, you can do digital charts and digital x-rays, and does that, just because you do Invisalign, make you a digital orthodontist? I have digital printers. I use a lot of them. I do a lot of Invisalign. Where I use Invisalign as much for treatment is in treatment planning. Not because I'm trying to understand, gosh, what am I going to do? I use it for education. Resin study models. Yeah, I do retainers, I do in-house aligners, and I do digital bracket placement sometimes. I still like placing the brackets myself. Communication. And when you're learning with digital printers, it's not plug and play. Do I do a lot of Invisalign? Yeah. And prior to about 5 years ago, 7% of my practice was Invisalign. Currently, it's 88.8%. I do a lot of it. Why? Because it works now. And we've scaled this within our office. So you can't hear it. We had one, and he needed a friend, so then we got 2. And then that friend got lonely, so then we got 3, and now we got 4. I use them every day, all day. So when we talk about communication in the digital platform, and Tom was talking about those videos, I hope you guys do that. So this was a case that I treated a long time ago. And the dad is an airway physician. So I was never going to be able to extract on this case. So I expanded him. So I expanded him with conventional expanders. And I went from 33 to 45. I went from 28 to 37. And he was still crazy crowded. He's retrognathic. He has no lower jaw. And now I'm looking at him, and I'm starting to say, I still want to take teeth out. And the dad comes to me and goes, well, you just need to use Marpy. I said, that will have no effect on the lower jaw. And so what's really nice about Invisalign software is I can educate everybody. And I do this routinely on all of my treatment plans. So I will develop 4, 5, 6, whatever the number is, of options. And then I set up a separate appointment for the families, and they come in and they see this. So in one option, I'm going to talk about distalizing the upper right, because I still want to take out an upper premolar and drop the canine in, and they said no. And I'm trying to explain to them that, look, if you don't want to do extraction in the lower, you're going to have to do surgically facilitated orthodontics in the lower, because you can see how far forward they go. So I don't think that's going to work. And I can explain it to them, but when I show them, I get a better way to get them committed to the needs of that patient. So now I'm going to look at the idea of taking out 2 lower bis and advancing the mandible surgically. That kills 2 birds with 1 stone. It gets rid of the perio problem. I don't have to do SFOT, and I could advance the mandible, and that actually is going to help his airway. And that's going to make the dad happy. Now, I still wanted to take out a bi, because if you don't take out a bi and you advance the mandible, you're still going to lose the second premolar or the second molar. So no matter what, he's losing a tooth. But they still wouldn't let me do it. So I had to distalize everything, squeeze the canine in. We did take out lower bis, and then we advanced the mandible. And so we used ScreenPal. It used to be called Screencast-O-Matic. And so this was his end result after we did the orthognathic surgery, advanced the mandible, and sure enough, you can see way back here, this isn't going to occlude with anything. So he's going to lose the second molar, and that's on them. So there's the surgery. This is what ScreenPal is. You create a square in here, okay? And then everything that goes in there, in that square, is getting recorded, and I have a microphone and I narrate it. And I can do this at the airport. So for the people that, Dave knows this, I don't send letters. It irritates them sometimes. Look, here's the deal. No orthodontist sits down and writes his own letters. They are with the treatment coordinator. The treatment coordinator takes notes, they check boxes, and then the letter gets drafted. And that's fine. Class 1 crowded, you're going to hear the same things over and over, and they mean nothing to you. If you have a complex interdisciplinary case, I can't write enough verbiage to get the picture that's in my head into your head. But I can send you a 3-minute video, and you can take notes and put it on the chart. So I'll do that. That's more efficient for both of us. So I apologize, I don't write letters anymore. Plus, I would be writing letters all day. Okay, here's another efficiency tip. Now, how often do I use the little video thing? All the time. This is called Text Expander. So it'll work on any program in your computer. You load it on your computer and you create what is called a snippet. A snippet is a code for whatever sentence you want. So all of that dialogue is the dialogue I use for distalization of molars in a class 2 case with Invisalign. And it's very structured. But I don't want to type it. I don't want to copy and paste it. Text Expander, all I write is, I have semicolon, distal. And it spits that out. And it would spit it out in Invisalign, it would spit it out in Word, it would spit it out in email. And so you create all the little things that you say over and over and write again, and you come up with 3 little words that you'd never, or however many you want. I just use the semicolon, and so all of my, I don't know, presets in Invisalign are all dictated. When I want a dialogue with somebody, I use 3 little symbols, and then boom, it spits it out. And it used to be free, now I think it's $50 a month. So let's look at some cases. All right, what's the first one? We're going to talk about gingival architecture. We're going to talk about augmentation, because sometimes I need more bone. So we're going to talk about SFOT, surgically facilitated orthodontic treatment. Is it new? No, it's been around forever. Here's a photo at the college where it was first presented in 1893. Okay? And imagine practicing like this. Hand belt, turning the drill, holding the patient down. So this was produced more readily in 1959. And so I pulled the paper. And these are the photos from the paper. And they actually do not look that different from what we do now. pretty cool. And what I thought was happening in SFOT was you would somehow damage the bone and then you'd be able to move the teeth with the bone. That's not what happens. You damage the bone and it calls in the signal that brings in more bone, and you've created an architecture for that bone to lay down as you're moving the teeth. So how does it work? It creates what's called a regional acceleratory phenomenon, the RAP phenomenon. It's not music. You create a corticotomy. The damage to the teeth or to the bone brings in bone generator cells. That's the secret. Some people then will put down a layer of bone and then a layer of alloderm and then a layer of gingival architecture. And then they suture it all together. It's pretty cool. A lot of people promote it as a way to do ortho faster. It's not true. So Wilcox, they're Wilco boys, they're two orthodontists, they pioneered it, they published it, and they talked about expediting orthodontic treatment. In all their studies that they did, they didn't have controls to compare the rates of tooth movement. And when they did it, they talked about how it would shorten treatment time, but they never evaluated the treatment time. They just noticed that you could move teeth faster, so they extrapolated and said, therefore you could shorten treatment time. Well, the weak link is the tooth that doesn't have SFOT because it's moving at the same rate as what you can do, which is 1 millimeter a month. Here you can move teeth crazy fast, but only for 2 months. That RAP phenomenon is only available for 2 months. So I use the ClinCheck to help me with SFOT, because the most important thing I need is adequate bone. And the phenotype of that patient is what's going to determine where I can move the teeth. Do they have enough attached tissue and do they have enough underlying bone? And if they don't, am I going to take out teeth or am I going to add either bone or soft tissue? So the periodontist is going to assess the phenotype, and they're going to look at the characteristics from patient to patient that are pretty simple to assess, and you can do it based on site-specific needs. So I might send the patient to Tom and say, hey, I want you to look at the canine, because that's the tooth that's going to move the most. And I've assessed that that's the tooth that's going to move the most because I've already done the ClinCheck and I can measure it. So I'm not only going to measure the quantity of tooth movement, but the quality of tooth movement. Because if I'm just going to tip that tooth, Tom's going to say, you're going to get away with free gingival grafting, it's no big deal. But if you want to avoid tipping so the teeth aren't flared and you're going to move that root, then we need more bone down there, so let's do SFOT. So that's what creates the perio-ortho collaboration, and that's where I use these ClinChecks. So Tom knows I've seen the patient. I've done my ClinCheck options. He's then going to see the options before he sees the patient. So then when he sees the patient, he tells them, I've already seen Doug's stuff. I know what he's asking for. Then the patient goes, wow, you guys are on the same page. I'm going to do whatever this guy says because Dr. Knight trusted him, and rightly so. And nowadays with Invisalign, you can actually upload a CBCT and it will show you where the roots are going to go relative to the bone. I don't have a CBCT machine, so I don't do that. So you can actually move the root, and it looks really pretty on the ClinCheck, but maybe now you've moved the tooth outside of the bone, and this will show you that. So that's pretty favorable when you're trying to assess need. So here's a quick case. Now, Felice is so charming, so nice, and her face is crooked. And she needs jaw surgery. But she's not going to do jaw surgery. But she doesn't like her smile. Is there something we could do to make her smile better? Well, what she doesn't like is that the right side doesn't match the left side when she smiles. The slant does not bother her. Blew me away. What she doesn't like is that there's a shadow in all of the pictures. So all of her pictures she takes on the right-hand side, so nobody sees it. So I said, well, this is pretty cool. And here's why this will work. The second molar is not in crossbite, and the canine is not in crossbite. I have anchorage to move those teeth. But if I use those two as anchorage and I start pushing those teeth out, do I have enough bone? And I'm starting to get the idea that I probably don't, because I already have recession here. And then the bone is at least 2 millimeters away. So if this is the CEJ, I already know where this bone is. And if I lose more bone, I probably lose the tooth. We've already got recession on the canine, so I sent this patient to Sylvia La Rosa, another periodontist in the area I use, and I can show her the ClinCheck. And then she can show me the CBCT. And then she can show me where those roots are going to go when I start moving the teeth. And there's no bone up there. If I have to move the root 3 to 4 millimeters to jump that crossbite, well, then I need 5 millimeters of bone. And I don't have it. So she sent me a letter. And here's the sequence. We're going to start creating that roadmap that I talked about. So the patient understands she's going to get ortho, but not yet. We got to protect the canine. So they're going to do a connective tissue graft first on the facial of 11. We're going to let that heal up. Then I'm going to take a new scan because the gingival margin's different. So I have a new scan, but I use the original scan for treatment planning. I'm going to use the second scan for treatment. And then we're going to do SFOT, and that has to be coordinated. So here's the graft. Here's the connective tissue result. It's healed up. Now we're ready for ortho. Now this is the surgery. So she put cuts interproximal between the bone. She laid down a layer of bone. She laid down a layer of alloderm. She laid down the gingival graft, and then she sutured it all up. And Tom, what's the hardest part about this after you've done all of that?
Getting the appropriate crown with the enzymes.
Yes. So one of the things, the most important thing they're looking at when they're looking at this, especially if it's in the lower anterior, is what are the depth of the vestibule? Because if he can't get that flap all the way up and get primary closure, this ain't going to work. And so if the vestibule, if somebody comes in and they're really shallow down here, you're limited on what you could do. If the architecture went up and this was really short, you couldn't do it there either. So here it is after suture. Now, there is a very, very specific sequence that we use as part of the Invisalign that's going to correct this. Okay? So you have to make sure the patient is on board with this before you get started. So now I've been able to correct this. And the sequence is very elaborate. So I start the patient ahead of time. Go back. I start the patient with Invisalign ahead of time. Well, I don't want to go through all this. I want them to be already used to the Invisalign before we have the SFOT surgery, okay? And the reason is that surgery is not inconsequential. You swell up like crazy, it hurts a lot, you're very uncomfortable, and so if now they have to get used to trays, they won't. And the rate at which they're going to go through the trays is different on the SFOT arch. So the first 2 trays they wear for 2 weeks each. They get used to it. It expands the PDL. Now the teeth are ready to roll. That's what we did with Rachel. That's what we do with all our patients. 2 weeks and 2 weeks. It sounds like we're being nice because we're giving them a grace period to get used to the whole process. The reality is I'm just working with the biology that's given to us. You start going through those trays at 1 week intervals right away, you're going to lose tracking day 1. So I wait. Now the patient goes in for SFOT. Tom says, I want at least 7 to 10 days before you start moving those teeth so that you don't strip my sutures and I lose primary closure. So that patient stays in tray 3 for 7 to 10 days. Now the trays have been sequenced. They're doing upper and lower. The lower trays are every 7 days, change out every week. The upper tray where SFOT is every 3 days. And so the assistant will go in, they know all about SFOT. So I don't have to explain this over and over. I tell the staff, hey, we're doing SFOT. They date all the trays for me, knowing it's 3 days for the top, 7 days for the bottom. But we're only going to do this for about 8 weeks. And then we have to stop doing the fast interval because we lose that capacity to move teeth really, really quick. Do we do it on young kids? Yeah. Angelo comes in. What do you see? What are you looking at as a periodontist, even though you're a restorative dentist? What are you guys worried about? Oops. Where are you? Down here. Well, we already have recession on 27, 26, and 22. I'm shocked that I got those numbers right because I don't use numbers. So there's crowding on the bottom, but not on the top. What kind of occlusion does he have? He's class 1. So whatever you do on the top, you have to do on the bottom. That's what class 1 means. Number of teeth on the top has to match the number of teeth on the bottom. So you got a number of options. The upper arch is looking at you saying, you don't need to take any teeth out. The lower arch is looking at you going, man, I'm not sure. The perio is what's telling you what you need to do. The perio is telling you either need to augment me or you need to take teeth out. It's simple as that. So you got some options. Non-extraction, extract 4 buys, or extract a lower incisor. Now if you're class 1, does a lower incisor work? You went from 4 teeth to 3 teeth. It works if you have what's called a Bolton discrepancy. A Bolton discrepancy measures what? The widths of the upper relative to what? Each other. And the lowers. It's not a measure of golden proportion. You measure the widths of the top. You measure the widths of the bottom. On average, we're going to use round numbers. Let's play pretend. The upper measures 50 millimeters and the lower measures 45. Now with class 1, you're going to get normal overjet and overbite. If you have a scenario where the upper laterals are a millimeter short on both sides, narrow, well then you have a ratio of 48 to 45. When you line it up, you're going to have prematurity anteriorly, or you're not going to be able to get to class 1. The incisors get in the way. So you have 2 options. You either widen the uppers or you narrow the lowers. That's where interproximal reduction comes in. So if you have no Bolton discrepancy and you take out a lower incisor, you're going to have 4 millimeters of overjet because you extracted a 5 millimeter tooth and closed the space. So it might help the perio, but you might not like the occlusal relationship. And what tends to happen in incisor extractions is you lose intercanine contact 100% of the time. Unless, what? You're class 3. If you're class 3, it works great. So those are the parameters that go into making all of those decisions. So I'm looking at the angle of those incisors. I really don't want to push them any farther and tip them. I'd really like to bring the roots forward. So now we're going to talk to the periodontist. And the periodontist has said, well, Doug, where are you going to move those teeth? And how are you going to move those teeth? Well, I want to move the roots. I don't want to just tip them. Because if you tip them, it makes the Bolton worse. It makes it look like the lower incisors are even wider. And so you'll get the anterior to couple, but you won't get the posterior to couple. So there's that perio interface. That's the amount of attached tissue that you have. If you run your fingers along there and it feels like a xylophone, you probably don't have enough bone down there to just blow it out and do non-extraction. So it's site-specific. Ashley Hoders was the periodontist in this particular case. She took her CBCTs and she said, Doug, you have no bone, but we can create bone. I said, all right, let's look at the clin check and I'll show you how much tooth movement we're going to get. So I did it with the family. And essentially what I did is I showed them the different options and she decided, okay, we're going to do the surgery. So she flapped them, she did cuts, and she did little holes. She put down bone, she put down tissue, and then she sutured it up. It was ginormous. But it made it really easy to do Invisalign. So 2 weeks with the first two, surgery, 7 and 3. Here we are progressing through. We're going through those trays as fast as we can. We've already leveled the lower, so I leveled the curve of speed, because the nice thing about Invisalign is it moves everything in 3D. So at the same time I'm correcting the anterior, posterior, and I'm widening things and I'm bringing the teeth forward, I'm also able to intrude that and lessen the overbite. So now I could finish him up. So here he is. His treatment time was quick because I didn't have that much to do in the upper arch. So it was 14, 10, 11 months treatment time, 10 appointments. That's efficient treatment. But they did have to go through SFOT. Now, that's where the tissue was when we started. That's where it was when we're done. Because she was able to gain both hard tissue and soft tissue. By the hard tissue being there, it'll support the soft tissue long term. But do we know if the hard tissue is really there? Yeah, because she took a CBCT afterwards. Here's the pre-treatment. Here's the post-treatment. So I like it. It's not on everybody, but it's dependent upon where I need to move the teeth. So here's a case that we worked with Tom's office when Gretchen was here. Here's Chris. So when you look at it, what are you looking at? Are we looking at the amount of crowding that he has? Are we looking at his restorative needs? No, we're looking at the perio. He's a really good toothbrusher. No caries, but lots of erosion. Lots of toothbrush abrasion. And so when I look at him, I'm starting to assess needs for alignment because he's worried about crowding. So I could treat him with 4-by extraction. I could treat him non-extraction. Extract a lower incisor. All the things that we go through. But just like the last case, he's class 1. So whatever you do on the top, you got to do on the bottom. He didn't have a favorable Bolton, and his issue with perio is not down here. It's in the posterior. So how do you manage that? Well, I sent it to Gretchen. And I looked at the idea of drawing a line from the nose down to the face. And he has some crowding, but not crazy crowding, so I didn't want to extract 4-bys. And Gretchen said, let me look at him. And Gretchen said, I can fix this, and I can help you out. And so she and I had a great exchange of videos. I mean, it was really cool. So she would look at him and send me the CBCTs. But then she had questions about how I was going to move these teeth. Am I going to move the roots out, or am I going to move the teeth? And in this particular situation, I needed to expand him. So she would send me a video, and then I would send a video. This was hers. You guys can't hear it. That was mine. So then it came back to her and showed her where I was going to go. So then what we realized is it's not just the posterior, it is the anterior. That gingival architecture was good. The underlying bone was not, based on the clinical modifier, which was the tooth movement. So what we ended up doing on him was SFOT all the way around. He was a very, 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 very brave man, because this was probably more significant than orthognathic surgery. Now, could you have done MARPI and orthognathic surgery? Because I hear that all the time. You need to expand him, use surgery. Okay, what kind of surgery? What kind of surgery expands the mandible? None. So you need SFOT. So she flapped him, she did the trauma, that brought in the wrap phenomenon in both arches. She laid down a layer of bone where she needed it, and then sutured it all up. I treated him with Invisalign, and these are the sutures. The Invisalign fits over it. The most important part of her surgery was getting that primary closure, and then making sure the patient brought the trays. Because my trays, I don't want them to impinge on her nice work. So as a result, she goes in and she actually trims the trays to make sure it's not going to be irritating. And it's not going to be irritating at the time of surgery, but more significantly, Tom, how much swelling are we going to get?
Well, it depends on how you do the procedure, Doug. The way that I typically do these procedures, I noted that both Sylvia and Ashley elected to place subgingival membrane.
Yeah.
And in the case that Sylvia did, she also did tissue augmentation at the same time. And I think that there's some positive things about that, and there's some negatives about
Mm-hmm.
that. One, for sure, Ashley had to raise a much bigger flap to get that photo. So that patient is going to swell considerably more if you're not doing that. One of the reasons why we don't have like a large social media account associated with our practice is I always felt like it influenced the way I did the surgery, not necessarily for the patient's benefit, but for the benefit of the documentation.
Right.
In some cases. So a patient like this, even though this is full thickness flap, induced surgical trauma of the bone, large grafting, they don't have big discomfort. If you raise large flaps and you put all these other modifiers in, then I think they would have significantly more discomfort. But to be fair, yeah, they'll get some swelling.
Yeah. And I've had some patients come back and go, yeah, it is okay. I have other patients come back and go, I'd never do that again. And it's the same way with jaw surgery. I have a lot of patients who come back and go, that was no big deal. My wisdom teeth was worse. But some patients, everybody's patient tolerance is just different. So now we did the staging just like we did with all the other patients. And it's so critical to coordinate this because occasionally I do this with braces cases. And in those scenarios, you're going to see the patient as the orthodontist every week. So I'm going to put in a new wire every week in order to take advantage of that wrap phenomenon. Well, if you do it during the summer and they had the surgery and then they're going to go to Wisconsin to see grandma for a month, I'm screwed. So you have to make sure all those appointments are on the books. So when we coordinate this, they've got the trays ahead of the surgery. They're comfortable with the process. They have the surgery done. Then I've got the follow-ups. And this is how his occlusion finished. And so he's got soft tissue now to protect, and it actually covered all the way down to where the CEJ was. And how much expansion did we get? It depends. So at the molars, we went from 51 to 55 in the upper arch. The premolars, we went from 42 to 45, and in the inner canine was 35 to 37. So you might look at that and go, well, that wasn't much. Well, maybe I didn't need much. Just because you can show a lot or you don't show a lot is dependent upon what you need. And so I was able to resolve that amount of crowding with this much amount of expansion. If I needed more, would I get it? Yeah, because I had so much bone to work with. So that phenotype modification, though, has its limits. So this is Casey. And Casey's going to be something that we're going to be seeing, and it's why Tom's practice is going to be successful for a really long time. His need is never going to go away. So Casey came to see an orthodontist a long, long time ago, and they treated her non-extraction. And this is very characteristic of what we're going to start seeing. They bonded a lingual wire from lateral to lateral. But look what happened in the intermediate section across the premolars, in both arches. The lower premolars collapsed. That pinched the first premolars and they squeezed buccal. This is the body doing what the body wants to do to put the bone, or put the teeth back within the bone. Everybody talks about relapse. It's not relapse. You're not going back to where you went. You're just changing. What holds your teeth in place is the balance between the lips, the cheeks, the gum, the tongue, and the bone. So I get adults who come in and go, well, over the last 5 years, and I'm 60, it really changed. Well, you got old. Sorry, but all those things, those balances changed. How I word it, just because I've been doing this 30 years doesn't mean I've become crass. I say, as we mature, and they laugh, Although I had an old crotchety man in today, so it was appropriate to get old and crotchety, and he loved it. So here's what's happening with her. Her teeth are going back to really the only place they can exist, as far back into the bone as possible. So it's collapsed and it's gotten crowded. The only reason she didn't come see me earlier, because she's mid-30, is because she had that wire up there. Otherwise, those incisors would be all over the place as well. So all those people that are treating to non-extraction as a dogma are going to end up with cases like this. So I sent it to Gretchen again and I said, can you help me out? Can we get some bone on the facial surface of these premolars? And she took her CBCT and we looked at it, and my video was sent to her and I showed her how I was going to move those teeth. She took her CBCT and she said, yeah, there's no bone on the facial surface of these teeth. You move them, they'll lose them. If I add bone, I don't have any bone to add to. There's already root. So we couldn't do SFOT. No matter how much we wanted, we couldn't. So we took out 4 bis. Now I pulled the teeth back within the arch, put them back within the bone, and now she'll see you guys and have gingival coverage to cover those roots. And they're at the same position that they were originally. But now we've got a stable platform so you guys can go back in and do your magic. You could still do your SFOT, but I don't have to move the teeth. And did we take out 4 bis and use braces or Invisalign? We did Invisalign. Why? Because she had so much crowding. The knock against Invisalign with Invisalign and extractions is when you move a root or move 2 teeth together across the space, the braces will hold the root in alignment. When you do it with Invisalign, it has a real strong tendency to tip. But if you don't have much space to go, and say you have somebody who's really crowded, then Invisalign works. Now I'll still do Invisalign on extraction cases, but I tell the family, you're still going through braces, because I'm going to close the space with Invisalign. That's going to take me 18 months. And then you're going to spend 4 months in braces because I'm going to parallel the roots, and then I'm going to pop you out and I'm going to finish you with Invisalign. And that works. And my fees are all the same, so it doesn't matter to me. I'll do whatever the family wants. If the parents look at me and go, well, if you're going to do braces, just do braces. And then the kid gets upset because it's like, Mom, he's offering us Invisalign. Just let me do it. Fine, we'll do it. And it's if the kid is good about it, that's great. So does Invisalign parallel the roots? Yeah, if you put the right amount of sequence into it. The secret with Invisalign, don't let Invisalign move the teeth. So literally, I move every single tooth with the 3D controls. Every single tooth. Now, this is going to sound odd. So I spend about an hour and a half every night doing ClinChecks. I have no life. But what does Janice care? She's watching Dancing with the Stars. All of our kids are gone. If I'm sitting there clicking Invisalign ClinChecks, she could care less. So it works. And when I go south, if you ever come to my office, it looks like an FAA flight center. I have 6 computer screens. I have 2 running off of my Mac. I never work on 1 ClinCheck at a time. Always 2 ClinChecks are open and the patient's chart is open. Greg Kinzer said to me once, don't you think you're short sheeting your patients because you don't see them enough? You see them every 3 months, and your visits are really 30 seconds just to find out how their golf game is going or how they're doing in school. And I say, yeah, Greg, but if you front load it and you spend that time, if I'm seeing 60 patients on a busy day with brackets and wires, I'm on the fly figuring stuff out. I'm not going back to the patient's chart and looking at the before, looking at the current, because I have a scan, and looking at where I predicted everything to go and have the x-rays there. But whenever I have a patient that I'm working on a ClinCheck, I'm starting at ground zero every time. I have the patient's initials, I have their progress, and I have their current. I don't ever get a chance to do that chair side, but I do that on every patient. And if you don't move every single tooth, Invisalign will screw it up. The first thing you do with an Invisalign case is you zero it out. So they're going to show you a cartoon that gets to the end result that looks good. First, you have to ask yourself, did they do it right? So here's something that happens all the time, right? We talked about this earlier tonight. There's a little bit of class 2. So how do you correct a class 2? Everything has to come forward in the lower, everything has to come back in the upper. So if you go and you click on the second molar, sure enough, you'll see they moved the lower molar 0.75 millimeters mesial. They moved the upper second molar 0.75 millimeters distal. That's 1.5 millimeters net. They just corrected your class 2, but you didn't add any mechanics that are going to do that. They just fudged it. So why do they do that? Well, the sooner somebody signs off on a case and it's 10 fewer trays on 11 million cases, that works for them. They're not there to hold your hand to tell you that this is going to work. They're there to give you a baseline from which you're going to direct the tooth movements. So I didn't do any Invisalign for a long time, but now you can move all the teeth. As soon as I could move all the teeth, I was all in. So everyone will tell you, wow, taking out 4 teeth, she's not going to be as pretty. She's going to have negative airway space, all of those things. There are actually some studies out there that when you bring the second molars forward, what do you think that does to the soft palate? It opens it up. If you have maximum anchorage and you extract and you pull everything back, then yes, you'll have less airway because you have less circumference. If you have reciprocal space closure and your molars come forward, you just opened up the back of the airway and you have actually more airway where it matters, in the throat. If you have, I'll just give you for an example when people expand. If you have no crowding and you expand 8 millimeters and you see the diastema at the MARPE lecture, and then you close that space, but there was no crowding and you didn't restore any teeth, is the net space for airway any different? Can't be. You have a piece of yarn, it's 8 inches long, and it goes from second molar all the way around to second molar, and you widen it. What do you think happened to the front of it? It pulled back. But did your volume, did your length change? No. Now, if you had crowding and you expanded things, then yes. But go to some of your meetings and ask those important questions. What are you going to do with the occlusion in the lower arch? What are you going to do when you close that diastema? Well, you're going to pull the incisors back because your posterior teeth are a bigger anchor than your anterior teeth. So what are you doing to the tongue space that you just said was so important? So if Tom wants to have me back and do an airway lecture, I would do that. All right, I want to show you one last case. This is why we do this. This is a tough case. It's asymmetric. She's class 1 on the left side, she's class 2 on the right side. She's got a retained baby canine, and she's missing both lateral incisors, and the canines are horrible in regards to the size and shape to consider canine substitution. Is this an ortho-only patient? Of course not. Otherwise, I wouldn't be presenting it. I'm going to think orthodontically, but I got to get out of my head and start thinking periodontally and restoratively. Because without those 2 factors, I can't fix this case. So I'm going to go through all of my ortho stuff, but I'm also going to start looking at the perio. I'm going to start looking at the restorative. What are we going to do? Are we going to open space? Are we going to do canine substitution? Are those canines good canines for canine substitution? No. A canine substitution case, you want a very short, flat tooth. When I say short, I want the embrasure from the marginal ridge down to the cusp tip to be short so that I can chop off the incisal edge and it'll look like a canine. There are actually 5 indications that we look at when we're doing canine substitution. And I have a whole lecture on it. It takes an hour and a half, and so we're not doing that. When you have canine substitution or opening space or asymmetry, having the ClinCheck is so valuable Because you and I get the picture. You're moving the canines. They're going to become the laterals. The premolars are going to become the canines. Parents can't get that. So I'll go through the occlusion type. Basically, if you're going to do canine substitution, you want a class 2. Why? You're missing 2 teeth on the top. That's one of the ways you correct a class 2 is you take out 2 teeth. So then the overjet will be normal. Does that make sense? If this molar is class 2 and you're missing a tooth, well then the overjet's going to be normal, 2 millimeters. Tooth size relationship. If the canine is huge, well then when you line it up as canine substitution, your Bolton's all screwed up. Because now the width of the uppers is wider relative to the lowers, you're always going to end up with overjet. The length, shape, and color of the canine. Not just the facial surface, the cingulum. Remember, you have to fit that relative to the lower incisors. The lower incisors dictate everything. It dictates where the upper incisors are going to be. So the lower incisors actually dictate what the face is going to look like, because you're always treating the uppers to the lowers. And if that cingulum is too thick, the secret on a good canine substitution case, from an orthodontic standpoint, is you're going to over-erupt the canine, because you want to bring the gingival margin down so that it looks like a lateral incisor, and then you chop the edge. Well, if the cingulum is really big, it runs into the lower incisors. And on a 12-year-old, when you start polishing the cingulum, they jump out of your chair. Yeah, I still use hand pieces, and it sucks. So if I never have to do that again, that will be fine. Now, you do it on an adult, it's great. Facial profile. If you're hugely retrognathic, you're not going to do canine substitution. You're going to open the space for the laterals, and if you're class 2, then you're going to advance the mandible. So all of these 5 things go into play when making this decision. So here's one that we did canine substitution on. And I kind of chickened out. I lined it up, and then I decided to extract the lateral incisor. Full class 2, missing canine on the right side, extracted the lateral, and she looked great. Here's one where the canines erupted next to the central incisors. Why do you want the canines to erupt next to the central incisors? Because it brings bone. If you don't have bone, you can't do implants and you can't get a good return. So you don't take out the baby canines. You leave the baby canine and you want the canine to erupt as close to the central as possible. Then you're going to take out the baby canine and distalize it and open the space, and then you can do your implants. And so these are the implants that were done when she was 18. She was also missing the upper second bis and 1 lower bis. So every time she was home from college, she invested in another implant. We'll see where that goes long term. And here's an asymmetric one. Asymmetric's really hard. Your eye always clues in to wherever an asymmetry is. Now this mom, he's missing the left lateral incisor, didn't even think he needed ortho, thought he looked great. Where do you think she's from? Yep. She was from England. She thought and her English accent was so charming. So I lined it up and then substituted the canine. It leaves a little bit of overjet because you're leaving him a little bit of class 2 on that left-hand side. So Lauren, maybe one of my favorite patients of all time. She went through a lot to get this. So I looked at the idea of taking out the baby canine and opening space for lateral incisors. So when we do that, that means I got to distalize it and get it into a class 1. And that's how you get opening space for laterals. Well, what about the alternative? Because that's a long ways to go to correct a class 2 in a non-growing individual. But most of that is through rotation. So that's a bonus. It's not pure distalization. What if we just do canine substitution on the right side? Well, if you look at it, what you're going to see is I have to pull the second, the first, and the second premolar that far mesial. I can't do that without plates or anchorage of some kind. And I end up with an asymmetry. canine substitution on one side and implant on the other, and that canine is sharp and pointy, so all of those are bad. So what we did is we got Ashley together and Jill Kinzer together and me and Lauren. And Lauren's at the center of this, driving the boat, because she has to be at her sister's wedding in Germany within about 18 months. And this is really hard treatment. And no, I didn't do this with Invisalign. So she went through a lot of coordination. This was when Jill was in Gig Harbor, Ashley was with Dr. J, and she would go back and forth. So she needed a combination of ortho, tissue grafting, bone grafting, implants, provisionals, provisional composites, and provisional crowns. So when you look at this, this is where the orthodontist has to think outside of the box like a restorative dentist. Why do we have this embrasure here? Well, there's one of two reasons. Either the roots are not parallel, or that's the barrel shape of an incisor. And I know the roots are parallel because you only leave the root in the implant site once in your career and then you never do it again. And yeah, I've done it. And you get to put the patient back into braces. So we knew that as part of the overall treatment plan, there were going to be sequences. Ashley was going to do some soft tissue grafting. And then we're going to let that heal up, and then Ashley was going to do some implants. And then when we're done, we're going to do some provisional crowns, but I'm going to use Mesh Mixer to create a template for Jill to be able to do putty matrix, to be able to do composite restorations on the canines and the centrals the day I take the braces off. So I do this sometimes for my dentists. And so I have Mesh Mixer, and with Mesh Mixer, it's a 3D program where I bring in some digital teeth, and then I can create sizes and shapes and put fake teeth in here, and then I can print it out. And then I can hand that to you, and you can use that as a putty matrix. And so this is a video that I sent to Ashley, and I sent it to Jill, and then I sent the model to her, and then she did the putty matrix the day I took the braces off. So all of this was coordinated ahead of time. So I'm sharing this with a digital scan, digital bracket removal. I've removed all the brackets digitally, a digital setup, and then same day retainers. So when the patient walks in, I've already fabricated the retainers. I take the braces off. She doesn't have to leave the office that day and feel stupid. She can go out and about, and she's got teeth up there. And then I share the story with the screenplay. So here's the Holly on the day. Here's the one that she likes to wear because it holds the teeth and has the fake teeth in there. Then she went over and saw Jill, who used my putty matrix to do the nice composite restorations. Now, because I created the setup for her, she could still use the Holly that I had already fabricated because the widths didn't change. Granted, I had to create a new Essex, but I can do that within 20 minutes in my office. So now, provisional crowns went on this particular tooth, both sides, and eventually we can put in the ceramic crowns. And so when you look at it long term, that's her smile. And so she gave me these photos. That was the before, that was the after. That was the before, and that was the after. This was her wedding. And that's where she got to. And then she moved. But she comes in and sees me every summer, and she gets a new scan, and she loses her retainer, and I send it to her because she's amazing. Any questions? It's 8 o'clock. That's it. Thank you so much for having me. I really appreciate it.
It's also going to be, it's going to have no bell there. We're going to have some technology brought in by no bell, so we can have an extra hands-on send out information as always, and make sure to sign the sheets as always, so I can send you the credits and a link to the video that we're going to put up on YouTube. Thank you all very much.
That's fantastic. Thank you so much. You're so welcome. I say congratulations on the She asked if I think I finished it up the first case she showed. She wanted to see how it finished. She
Oh, yeah.
or just texted me one. It was the one where you were showing, like a 3-year stay.
Yeah.